Dr. Katharine Smart is the president of the Canadian Medical Association, and Dr. Michael Werner is an ICU physician and the medical director of critical care at Toronto's Michael Garron Hospital. Docs, thanks for your frontline work. Great to see you. Dr. Werner, let me start with you. On Twitter today, you called into question why the Ontario government was cancelling surgeries when they have the ability to ramp up hospital beds by another 500. But you also said, what's the purpose of beds if they don't have a staff? Can you give us a picture of what you're seeing on the front lines?
So Evan, here are the numbers. So in Ontario today, there are 1,850 ICU patients in beds. The government says that we have 2,343 patients. So if you go to their website, there are 493 empty beds. Minister Elliott says we can ramp up another 500 on top of that. So that's nearly 1,000 beds we have at our disposal, according to her. So my question is, if that's true, which it isn't, then why are we canceling cancer and joint replacement surgeries in Ontario? It doesn't make any sense. You can't have it both ways. The truth is, we can staff the beds we have, those 1,850, but the most we ever staffed at the peak of wave 3, when we had 891 COVID patients in Ontario's ICUs, was just over 2,000. And on that day, we moved 25 patients across the province because of excess patients in certain hospitals. So I think the government, and I'm not expecting them to fix the healthcare system in the middle of a pandemic, but I think they need to be honest with people, because it is really troubling to those of us working in the hospitals to be told that we have all these empty beds with staff available, because it simply isn't true.
Dr. Smart, are empty beds a false metric to keep track of when hospitals across Canada, as Dr. Werner is saying, basically are saying, we don't have the staff, so these beds are useless because no one can work them?
I think, Evan, this has been a challenge throughout the pandemic, is transparency of communication and really asking the right questions and talking about the right things. You know, as we're hearing from Dr. Werner, this is not a new problem. We often have governments presenting one thing to the public, which is sort of beds on a piece of paper, without really diving into the importance of the human health resources that staff those beds. And right now, with the Omicron wave, we've got the double whammy of healthcare workers who are exhausted from the ongoing pandemic, but also many of them being infected themselves. So we're short-staffed on top of a burnt out and exhausted workforce. So those two things really play into what those bed numbers mean. And I think the public deserves honesty around what the actual capacity at hospitals are.
Yeah, so Dr. Werner, let me just flip back to you, because today Doug Ford was hinting that later this week he's going to relax public health restrictions. You've got schools are already back, and everyone's talking about the peak is past. So when you hear that, through your eyes, looking at the system, what does that tell you? Is that the right call?
Well, we're at a record number of hospitalizations in Ontario today. You know, I'm not going to weigh into the public health measures piece, but it's very important for the public to understand that, let's say we've peaked. Let's say today's the peak in terms of cases. You know, just as many people or even more people can be infected on the downside of that peak, because that peak can be drawn out longer than the upward swing. I know that people like positive momentum, but the hospital peak, I think, is weeks or months away. So the question is, you know, we're hanging on by our fingernails now, and does it make sense to open things up when we really need to prioritize getting kids in school and making sure that's done as safely as possible? You know, I know businesses have taken a major hit, but Omicron, I think, you know, we hoped for the best case scenario. I hoped for the best case scenario, but it's proving not to be as mild as we thought when we consider the number of people infected and the number of vulnerable, unvaccinated and undervaccinated people we have in this country.
Okay, Dr. Smart, is that the case that you know, people in Quebec, they're talking about the peak, but the peak has different meanings, like the words matter here. Doesn't mean that everything's going to, you know, start slowly go down. We still have hospitalization, there's short staff. Give us what we should be expecting to see in the days and weeks to come here.
No, absolutely. You know, we're talking about a peak of what was an exponential rise. So there are still many, many people who will become infected. And we know that hospitalizations lag behind case counts. So by no means are we out of the woods in terms of the impact on hospitals. And we know often the pressure on hospitals can be delayed. So I think, you know, we aren't there yet. Our healthcare system remains very distressed, understaffed. It's being overwhelmed. And again, you know, we're seeing that cancellation of other procedures that people need. So I think we all want this to be over. You know, no one is more ready to move on than healthcare professionals, but we've got to continue to hold tight here over the next few weeks until we've really got our healthcare system back to a capacity where it can actually meet the needs of everyone who needs it. And that's not where we are right now. And I don't think that's where we're going to be in the near future.
There's been a big fight, Dr. Warner, about just how we talk about this in a realistic way. Bed availability, maybe that's masking the truth, which is staff availability. So what's the best way to talk about it, whether it's bed availability, hospitalizations, fully vaccinated patients in ICUs or not? There's a lot of wiggle room here. Give me your take on what we should be talking about in terms of what we need to measure.
Yeah. So I think if I was an average member of the public, I'd be completely confused. So, I'm not a politician. I'm just going to tell you straight what I think. So I think staff beds is what matters. Funded bed, that term is meaningless because if there's no one to work the bed, it's just a piece of furniture. So let's figure out what the supply and demand we have of staff is, or given that's a dynamic thing as well. And then when we look at vaccination, so every day, Minister Elliott will tell you how many people in the ICU are quote unquote fully vaccinated. That definition is 2 shots. I can tell you, after treating 200 COVID patients, I've only ever admitted a patient with 3 shots once. Okay, and that patient had an organ transplant. So we need to be truthful that this is a 3-shot vaccine. And if you get 3 shots, you're very unlikely to be seeing me in the ICU. I think that would help with vaccine hesitancy, and that would remove a talking point for anti-vaccination people. And I think the government is actually not doing themselves a favor by using that term. Okay, so 3 shots, 2 shots, 1 shot, 0 shot. That's how we should be categorizing the patients in the ICU and in the hospital, because that will show people that the vaccine is incredibly effective at preventing severe illness.
Dr. Katharine Smart, just weigh in. Last word. Do you agree with those measuring sticks?
Oh, I couldn't agree more. Staff beds, and absolutely, this is a 3-shot vaccine. You get your 3 doses, you are going to be protected. And those are the key messages that we need to be communicating to the public right now.
Staff beds, not funded beds. 3 shots, not 1 shot. Dr. Katharine Smart, Dr. Michael Warner, thanks for that. I know you both are exhausted, but I appreciate you coming on for the messages. I appreciate it very much. Thanks.
Thank you.
Thank you.